All right, so again, I'm Jason Wagner. Ben and I are going to spend a little bit of time talking about performing procedures and teaching procedures both at the bedside and in other environments. So, I don't know, I like my cartoons today. Who can share a story about a procedure gone poorly in kind of the education environment? Does anybody have a story of like that disaster procedure? Not personal maybe, but where you're the educator?
Everybody's learners do perfect procedures all the time.
At least that's what documented.
First attempt.
A senior resident who was very soon about to be an attending, who was doing an intubation on a patient. This was back in the COVID days when your patient would go from like 90 to 40 within about 2 seconds. And when he got past the cords, he kind of jammed the tube as quick as he could, and the tube actually kinked anteriorly, and so then the tube essentially U'd, and so couldn't advance the tube any further. And he just kept kind of jamming and jamming and jamming as the sats were going lower and lower and lower, to the point where I actually booted him out. He got ready for crike, and when he had the scalpel at the neck, like I pulled the tube out and put it back in, but there was just like he didn't know what to do. It was such a bad moment, and his only response was, just jam.
The brute force move forward, man. Didn't have a failure algorithm for himself. Yeah, absolutely. Definitely something that can come up for sure during procedures. Other people? Did other folks have? I heard you had an exciting one around sign-out.
Are we going to share that? I know we're going to share that, but and this was we had prevented it from happening. But I was receiving sign-out on a night shift, and a med student came up and said, "Resident X wants to know where the large spinal needles are," and we had just finished sign-out. I'm like, "There's nobody that needs a lumbar puncture, so why are they asking for a large spinal needle?" And they said it's for the subclavian line they're trying to do. And I was like, that sounds like a disaster about to happen. And you go in to find a resident just completely struggling with the subclavian on this obese patient and trying to, they want to use a 6-inch LP needle for their wire needle now. So we quickly averted disaster with that. But that is an example of stepping in, and that's another thing to think about. And this was going to be an example of that, but you guys saved me from having to use one of these disasters as a teaching model. So we are going to go through a stepwise approach to this, and the model's called the four-step teaching process. We break it down into just a little bit more than that, but we will walk through these steps as we go and use this as our frame. I'll give that to you.
Awesome. So there's
Top button advances.
There's kind of two rough categories that we're going to talk about today. Number one, which sim with lots of time to train. So let's say you're in the sim lab, you've got lots of time, you've got all the time in the world to really sit there and work with your learners on mastery. And then there's kind of different procedure teaching, which is you're in the clinical environment, you're ready to go. The patient needs an intubation, not 2 seconds from now, not like right now, because probably isn't time to teach in that moment. But you've got a couple of minutes, you've got a little bit of time, and you've got to get them ready. You've got to make sure that they're in the right headspace. They're going to be the right person, going to do the right procedure in the right way. So we'll talk about kind of both those models and what they look like. And we're going to start with the sim lab or the classroom environment where you're teaching in a nice, calm classroom didactic environment.
The top one advances. The very top.
Oh, the top. Okay.
Yeah.
All right.
You're on that one. So that was your just in time.
This is okay. So this is just in time. All right, I see. So here's your clinical environment, and that's where you might be getting ready to intubate this patient. Again, he doesn't look like he's gonna do too well on the BiPAP for too much longer, but you're not rushing to put the tube down right at this very second.
All right, so Ben is going to cover that just-in-time model. I'm going to cover the four-step teaching process in a more controlled environment. Okay, so this is where we have time to teach and educate. That's our goal. We're not caring for patients in the immediate environment. So a couple of things to think about first is who you're preparing for this process. So in this environment, it's really the learner that we're there for. We're preparing the learner for the procedure. You don't have to worry about the patient and what's happening to them as you prep the patient. So getting your learner to buy in on the process is the most important part of this. And I was a sim director for almost a decade. This mic's going to make me a little crazy. The thing that I really tried to think about when I developed sim was that the things that my learners needed in that sim environment were present and available for them. So very often, I think most of us have had sim in our education now. You have a sim setup and you expect the learners to utilize everything in the sim lab, and then they want something and you're like, oh, just pretend that's there. And like you create this like double artificial world now. It's like, I want you to utilize everything in the environment except for that one thing you really want, just pretend that's there. And so when you're prepping for procedural training, you need to make sure everything they need for the procedure is available. Don't have a used central line kit that's missing the needle they need to actually perform the procedure, things like that. So prepping the learner, prepping the room is the first part here. And then we'll move on now to the conceptualization phase. And this is where your learner is talking about the procedure, how to go about the procedure, and they're engaging you in discussion about the procedure and making sure they know what they need. And I think when you think cognitively about this, for an intern, that might be all they can really do right now is discuss all the things they need. They might not even know how to utilize those tools yet. So you have to keep your learner level in mind when you're doing this conceptualization phase as well. And now you're going to actually walk through the procedure, visualizing. And so this is where we start with the four-step teaching process here. So I, as the instructor, and so this is step one of the four-step process, I'm going to go through the procedure at normal pace, and the learner is just going to watch me. And they're going to visualize the process of properly performing the procedure. So, and I think the second part is maybe one of the often forgotten parts of this is the learner should be observing from the same position they're going to be performing the procedure in. Now, this can get a little challenging if you're a righty and they're a lefty and you're doing a procedure with your dominant hand that might be different for them. You have to keep those things in consideration, particularly with central lines. So after I performed the procedure myself, so they've watched me perform the procedure, now I'm going to step to the next stage of this where I'm going to actually go through the process again. So step two now, the four-step process is me performing the procedure while describing the process to the learner. So now we're going to go through the little intricate details of the process. So they've seen it happen once in real time. They're now going to watch me perform it in a more broken up stepwise fashion. This is where you can add in all your little tidbits about like, oh, I like to hold the needle this way. One of the things like dumb little things. When I do central lines, I aspirate with my finger on the back of the needle barrel, and I use like my ring finger to pull the barrel back, or to pull the plunger back. And it never occurred to me that I needed to teach somebody how to do that. And then I was watching one of my instructors teach somebody else how to do a central line, and they held the needle in a completely different fashion than the way I did. And it was one of those things where it never occurred to me there were two ways to hold the needle until I watched somebody else do it. So it's little, like those little micro teaching things are important in that phase. So now I've gone through the procedure in real time. I walk through giving a little micro teaching as we go. And now this is the kind of new part, I think, for a lot of people. Now this is where the learner is actually telling me how to do the procedure. So I only do what the learner tells me to do. And now they have to try to walk me through this process as we go through it. And you're going to get stuck in spots because they're going to forget components. Ideally, you let them work their way out of it, but if time doesn't allow for that, you can give them a little help along the way. And then we get to the last part. So they've done the verbalization now, and this is the part that we're used to. This is the part that we most commonly do, and that's talking the learner through the process, the learner doing the process in front of us. And I think most of us skip right to this last step first. So we give the learner a bunch of equipment. We say, put in that central line, go. And then as they do it, we critique and give input and help teach. So we're kind of flipping this now. We're performing the procedure. We're talking about the procedure while we perform it. They're verbalizing the procedure back to us. And then finally, they do the procedure on their own while verbalizing what they're doing to us. And so with that, we're going to take a minute to practice this. So if you happen to have shoes with laces, you're set. If you don't have shoes with laces, we have laces for you. So you'll have to
Take one of these. These are more fun anyway.
Those New Orleans-based laces, they look very Mardi Gras.
They were just the finest I could find at the band store.
In case you don't know how to tie your own shoes, we got a little cheat slide for you here. So what I want you to do is, with your partner that you've been working with here, we're going to walk through this teaching process. So one of you is going to be the learner, one of you is going to be the teacher, and again, we're going to use the 4-step process. So demonstrate with verbal cues, the learner tells you how to do it, and then finally the learner does it while explaining what they're doing. If you want a real challenge, and I think from a time perspective we probably can't do both, if you want a real challenge, tie your shoes the opposite direction from the way you normally tie them. So if you want to challenge yourself, instead of throwing left over right, throw right over left. So work with your partner and practice the 4 steps here. We can go to this, and just remember it's conceptualizing is when you perform, visualizing is when you perform for them, along with the step where you perform, they watch, you perform while explaining, they watch. That's the visualize. The verbalize is when they tell you what to do. Supervised practice is when they do it while explaining to you what they're doing. Remember, a key to this, the first step is that they are in the same orientation as you are. So if you're teaching them how to tie a lace, you want to have them looking over your shoulder, ideally. Unless you can teach backwards. Think about like how women can tie a tie on men generally, facing forward, but we can't do it ourselves. Yeah, reminder on the steps again. It's you perform while explaining, they tell you what to do, and then they perform while explaining what they're doing. This is where you all realize how hard it is to tie your shoes, right? Who knew it was so hard? Did they go? All right, we'll do like one more minute. I think everyone's getting the gist of the process.
All right, if you guys want to wrap up your teaching sessions, I think we're going to get back to this here. Maybe we'll take a quick another meta moment here to talk about the actual teaching exercise that you guys just did. We actually spent quite a while trying to stop and think about what was sort of the appropriate level of simulation for this. What was the level of complexity that really illustrated the difficulty with actually teaching multiple steps of a procedure that has some detail with it. We had talked about little subclavian simulators, or we had talked about knot tying, but yes. We're sorry about the lack of Sazerac. I think it's an important consideration if you're going to do something like this in a didactic session at your own shop. What is the level of fidelity of sim that's going to be the best illustration of your point? So I guess we'll solicit some quick feedback from the groups. How did that go? What felt difficult? What sort of came naturally? What did you guys think?
It was just something that we do, a million times and don't even think about it.
Yeah.
So we try to put these simple motions into a digestible form for the listener that's challenging. It's easy to overbreak it down, I think, little maybe irrelevant hand motions.
Does that feel like it has relevance to procedures that you can do without a second thought in the emergency department, but that interns can't? That's sort of the way it feels, especially if you're trying to switch hands and tie your shoes the other way. Wow, all of this muscle memory that I had, everything that felt natural and easy before, all of a sudden I got two left hands, and I don't know how to get through this in an easy way before. It's hard to break it down when you have that kind of mastery level. So good to think about this. What are other people's perceptions?
It's a thing called the curse of the master. It says you get further removed from the origin of your knowledge, you forget the little bits that make up what you already know.
Yeah. Value of things like near-peer teaching. Go ahead.
I mean, I'd definitely say doing it the other way suddenly felt like a totally different skill. The same thing is the other way.
right?
Like, what am I doing?
Yeah. So also, the value perhaps of knowing multiple ways to do something, to kind of accomplish the same task, like really important in emergency medicine, because obviously our first choice is not always the one we can accomplish.
You want to mention your wife's story?
Yeah, I heard this group talking about it actually. Did anybody discover that there are different ways to tie your shoes today? Something that we all thought would, is a pretty universal skill. But I, learned about my wife, not that long ago. We've been together for a while. She ties her shoes totally differently than I do. She does the 2 loops thing that you guys were talking about. I was like, I didn't know that was a thing that you could do. What did you discover over here?
There is a lot more like, I like a wrist flip.
Fancy tire, I guess.
So, go ahead.
I was going to say, I also had this moment of like, I need to be standing behind him to like watch all this happen.
Yeah, absolutely. The value of that perspective. So, one of those things of like, it seems like it's okay if you can just watch this procedure from anywhere and you can kind of put yourself, but no, it is much easier to kind of master the skills if you're looking at it from the right perspective. So, simple things like body positioning, tremendously important. But it does. It goes to illustrate the value of those sort of micro skills. Everybody's going to have a little bit different ways that they accomplish things. Maybe somebody's got a fancy wrist flip that they do that really works for them. Maybe it'll work for you too, but I think breaking it down into those little small pieces so that you can see how that works, do the wrist flip this way and not this way, I think tremendously important.
Yeah, and go ahead. Sorry.
I was going to say, what if you're a lefty teaching someone who's right-handed, or vice versa? You have a resident or a student who's a lefty, and you're right-handed.
We beat that out of our learners quite early in the
I'm left-handed, but I call myself the once I'm right-handed because I don't think anyone ever demonstrated it left-handed.
We only accept right-handed. Sinister. From the front end, yeah.
I remember that from course.
So along those lines, there's this huge upswelling interest around mastery learning checklists and having people get checked off, and they get very, very down to the minutia. And there's some resistance that comes up with people that have done it a different way, very successfully, like their whole time around that. I was curious about what you guys think about that.
I think that's a great point. And it's one of the things that made this come to mind for me as I listened to an NPR segment on the study of the physics of ropes and knot tying, and that there are some knots that are stronger than others, and every knot you put into a rope decreases the tensile strength of the rope. And they were talking about tying your shoes, and that I didn't understand either, but many people don't tie their shoes with square knots. They tie them with granny knots. And so granny knots come loose much more readily than a square knot does. So there is a right way to tie your shoe when it comes to the type of knot you put in. So to your point, there is a best practice and a right way to do many of our procedures. So you have to decide, is there the way that they've adjusted or the way they perform their procedure, is it an acceptable variation, or is there a standard they should be learning instead? And I would think it depends on the procedure and what their variation is.
Yeah, absolutely. So I think we'll move on at this point. I think you guys really got a great sense, hopefully, of how these steps play out in real life. But now I think really important to figure out as well, how do these relate to the bedside? When you've got a patient that's going to need a procedure in the very near future, what kind of things are you needing to give to them? We talked a little bit about feedback. You want this overall to be something that's very behavior-based, very specific and immediate. Make sure that it's outcomes-oriented and kind of focused on the patient. And then, is this something as well in the clinical environment, before we get to just in time, of, do they need a formal assessment? This kind of gets back to the checklists. Is there a checklist that you can use? Is there a mastery learning assessment that you can get to? And then, importantly here, you wanted to prevent propagation of bad techniques. So really important, both in the sim lab and in the actual clinical environment, to step in, and when you see bad habits starting, then you've got to put those to a stop immediately.
Yeah, I think that's when our residents, our teachers, we have to make sure they're teaching properly.
All right, so what does conceptualization look like? These are the same steps as you just did in the sim environment, but now they've got to happen a little faster and maybe a little bit differently. So when you are thinking about whether your learner is the right person to be doing this procedure, ask them to talk you through this procedure. What do they know about it? Why is it happening? Are there any patients that you wouldn't perform this procedure on? Are there considerations that need to be thought about? What kind of equipment are you going to need to bring? Are there anatomical landmarks that you're going to need to identify on this patient? Are there considerations that you're going to need to make because of the patient's body habitus, because of the patient's NPO status? What do they know about kind of the complexity and the nuance of this procedure? Because if you can get them to describe this in great detail for you, if they really know the ins and outs of the subtleties of this procedure, the chances are they're going to be able to perform it really well when it comes to real life. If not, there's a great opportunity to educate and fill in some of the gaps for them, even before you've laid your hands on any sort of equipment or come anywhere near the patient's bedside. So really make sure their conceptualization of the procedure is on point.
Airway is my big area of focus I really love, and there are a lot of people who will say an intern doesn't touch an airway until they can describe every stage of the process to prep a patient to be successfully intubated. I don't go quite that far. For us, a more general rule is no intern ever intubates a trauma patient, because trauma patients, if they go south, like trauma surgery is never happy, and the patient ends up with like a scalpel in their neck. So you have to learn, you have to pick that right patient for your learner.
So same thing as before, verbalization. You want them to talk through all of the steps of this procedure. You want them to do this ideally outside the patient's room. So they're in the mindset, they're ready to step into this patient's room. They are like, wow, if I don't get this right, chances are things might not go well in this patient's room either. So they should feel a little bit of that pressure. And if they can't do this, like Jason was saying, are they the right person to be performing this procedure? This is a little different than the sim lab, where you've got all the time in the world to kind of keep doing deliberate practice and multiple rounds of iterative improvement. At some point, if a person is not trustworthy, if they can't talk you through everything that you feel like needs to be done to keep this patient safe, it might be time to go find that senior resident or the more experienced person. Or make sure that you're really in a position in terms of the clinical load and how the department is doing to be able to provide a lot more hands-on guidance. There's a lot of fairly inexperienced folks that can be coached through a procedure if you're really right there beside them, kind of doing really everything with them and providing that corrective feedback in real time. But ideally, they should be able to do the vast majority of this, verbalize all of the important steps, at least what you view as the critical actions for this procedure that you're going to do. You also want them to be able to set up the equipment. So this is kind of part of being able to do the procedure. Do they know how things go in the LP kit? Do they know where to put the drapes, where to put the tubes, how to get the numbing medicine, the betadine, everything in kind of the right spot? Because if they don't, they really might not know as much about this procedure as they think they do. And then visualization has another really important correlate. I'm sure all of you guys have done this or seen this being done on shift. Pull up a visualization. Visualization doesn't have to just be in your mind now. We have this great thing called YouTube, and it turns out that there's tons of great, really valuable medical education content up there. And, there's no shame in this whatsoever. Maybe you haven't done a knee aspiration in a while, or maybe your intern has never done one, and maybe they understand kind of the theory, but it's always nice to watch somebody do it in real life before you're about to do it. That's going to make you better. That's going to make your learner better. So no shame in this. Ideally, maybe this isn't something that you want the patient to see, because I think maybe some of the optics around that are not ideal.
Your patient might be looking at the same video at the same time.
Right. I promise this looks easy in the book. But This can be a really valuable teaching tool. So don't be afraid to say, yeah, you know, I haven't done this in a while. Let's watch a video and let's just get up to speed. And you know, then you can actually do some teaching in real time with them. You can say, oh, watch, this is a really important part of the process. Make sure, I like how they're doing this, or you know, this isn't how I recommend doing that. You can teach alongside with the video. So a really valuable opportunity to augment your teaching there. And then just review the procedure in any way before entering the room. Whatever form that takes, if they just want to sort of visualize their success, even visualize failure and how they might recover from that. This is something new that we were talking about yesterday, that you know, this visualization often gets talked about as, boy, you know, you visualize yourself like winning the race or you know, performing this really difficult intubation, but maybe more valuable might be, well, what are you going to do if things don't go well? Do you have a plan for when you can't see the cords, or when you know you're tugging on that hip and it doesn't go back into place? What are your next steps? Because I think having that failure algorithm, as kind of alluded to here, you know, you don't want to just keep jamming the tube. That's not a failure algorithm. So thinking about what your steps 2, 3, and 4 are in advance, I think is a really important part of this visualization process and conceptualization. Think about using a mannequin or a task trainer. Maybe you guys have these in your ED, your clinical environment, or maybe close by. This is a great thing to do. You know, we've got a mannequin head just kind of stuffed in a drawer. And you know what? Maybe right before you're about to head into the intubation, be like, hey, you know what? Let's get our laryngoscope out and let's just go through this real quick. Let me watch you, you know, demonstrate your muscle memory with this. Let me watch your fluidity of motion and you know, how you do these body movements so that you're not kind of flailing all over the place. How do you really demonstrate that you understand what the subtleties of this procedure are? There's nothing like watching somebody do something to be able to be like, whoa, wait a minute, stop. Let me fix something that's really going to maximize your chance of success here. Maybe somebody's just grabbing the laryngoscope and just shoving it all the way in. Okay, great, we can fix that right away.
I had an intern who, we were preparing to intubate, I was doing this, pull the head out, but let's just do one intubation on the mannequin before we go in the room. They grabbed the laryngoscope with their right hand. And I was like,
Boom.
we're not doing this anymore. That is a left-handed weapon, it's not a right-handed weapon.
So much valuable information. They didn't even have to say a word. So really encourage you to think about these sorts of things. You know, if you, again, this is sort of that extra procedural kit. You know, if you've got lumbar puncture to do, just have them kind of pantomime what they're going to actually be doing, because you really can, this is an actions speak louder than words kind of thing.
If you get an airway, I think very underutilized just in time. It's so easy to take 2 minutes.
Absolutely. Then think about preparation, and this is really preparation kind of at the bedside. Now you're not in the sim lab anymore, so you've got some more stakeholders in here, and it's important that the patient kind of understand what the setup is going to be, because this is kind of a dicey situation. You've got a learner who may not be quite as experienced. They might not have any real life experience beyond the sim lab in doing this procedure. So you got to let them know what's going to go on. How is this going to work? Let them know that there's a learner that's going to be involved, but that you are going to be directly supervising their experience and making sure that nothing goes wrong, that it's, you know, they're sort of getting the benefit of both providers, and that there's going to be some discussion and guidance that's going to go on. Hey, we're going to talk some shop here. Don't worry about it. This is kind of part of our normal back and forth, but if you hear us talking, that's totally normal. It doesn't mean that anything is going wrong with your procedure necessarily. Great, that's going to go so far to reassure the patient and help them feel like, yeah, this is not, they're not being experimented on, they're not being sort of victimized by this. No, it's a teaching hospital. This is part of what gets them this, you know, top quality care, ideally. And you want to set things up properly with your learner. Let them know that if you see them making a mistake, you see them kind of doing something that they ought not to be doing, that you're going to step in. You're going to correct errors immediately. You're going to maybe grab their hands and sort of guide them in a different direction. You might stop and restart part of the procedure. Actually, I'm going to have you take that suture out and just kind of rethrow that in a different way. Okay, great. You know, that's going to happen. That's totally normal. I think just setting them up for success as well, so that they don't take the first sign of correction as, oh my God, I need to throw up my hands. Here, you just do it, because I think we've all kind of seen learners sort of react in maybe not so great ways to feedback and guidance from procedures before. So how should this work? How do you guide a procedure? Well, you kind of need to be there. It's difficult to supervise procedures well from across the department. Not saying it's never been done before. Certainly, maybe there are those senior residents that we'd feel comfortable taking care of our family members that you can be like, you know what, I'm going to supervise that intubation from over here. Looks like you're doing a great job. You keep up with that. So think about the critical points. What are the critical points of the procedure? Maybe you've got somebody who's prepping for a lumbar puncture and they've done a bunch of them before. You don't need to watch them set up for the procedure. You don't need to watch them drape and put the betadine on. You have a pretty good sense that they're going to do it, but they want you to be there for the actual critical action of putting in and redirecting that needle. Okay, great. Maybe that's the critical action for that particular procedure versus for a brand new day one, July intern. Everything is part of the critical procedure. So you might need to be there from moment one until everybody steps out of the room. So what is their level of ability? What is their level of experience? And the thing that I would say with this is be prepared to be surprised. I've definitely walked in the middle of senior residents doing procedures, and I'm like, you're not as good or as experienced with this as I imagined. Or interns that are like, yeah, you're amazing. You're suturing this like a plastic surgeon. I have nothing to offer here whatsoever. So, do some spot checks from time to time. I think that everybody likes to assume, oh, the senior residents definitely got it, but sometimes they don't got it. So make sure that this is something that, even if you have some assumptions about their level of experience and expertise, that you double check. And then stepping in, what does that look like? How do you do that in real life? Because you don't want to say things like, oh, oops, that doesn't look so good. Oh, no. That's going to make the patient uncomfortable. You wouldn't want that done to you. So how can you avoid that? You do need to step in. You can't let the learner kind of make a mistake, do anything that's going to harm the patient, or develop bad habits. So think about phrases that are going to not necessarily give away or betray that things aren't going quite the way you might imagine. So I like the phrasing that's put in here. To address this issue, I like to try and redirect the needle just a little more flat. Try coming in from this angle instead. Some people may do it that way, but I personally prefer this way. You don't have to say, the people that do it that way are totally wrong. Those are incorrect techniques, and you should not follow that in any way. But I think just finding that ways to give that gentle guidance. I like the technique that you were talking about yesterday of if you call the learner by their first name, John or Sally, this is really going very well. You keep the needle going in the direction that you're going. That's a good sign. First name is good, but if you call them Dr. something, so-and-so, oh, Dr. Smith, it might be a good idea for you to hold on for a second. So if you first name good, last name corrective feedback. So give them a little subtle signal that there's something that they need to pay attention to, or that they need to pause and reconsider. So think about those ways, talk about them with your learner ahead of time, how you might want to actualize that corrective feedback in the patient's room without making them concerned. So there's our model. Once again, thinking about preparing, conceptualizing the entire procedure, visualizing either just in their head or with the aid of a YouTube video, verbalizing the steps of the procedure, both kind of teaching it back, and then doing some guided supervised practice, breaking it down into those micro skills, the small steps to make sure that everything is really on track, stepping in when you see bad things starting to happen before they actually happen and harm the patient or become a habit, and you should be in good shape to teach procedures. That's all we got. Does anyone have any questions? All right. Thank you, guys.